Keratoconus is a pathology that affects the cornea and the lens, which is the first part of the eye and also the most powerful. It has an average power of 43 to 44 diopters. It has an aspherical shape that is more curved in the center and flatter in the periphery. A normal cornea must have the most similar curvature qualities in its various parts, at least in the center. In the case of having keratoconus, the cornea takes on a conoid appearance, which means that it becomes thinner and more curved in the lower and temporal part. For the patient, this means a diminution of the visual capacity, halos around lights, astigmatism, and myopia. Usually, the patient with keratoconus is presented to the ophthalmologist because he or she has a decreased vision, and it mainly affects young people, perhaps adolescents, prepubertal, and puberty. Up to 30 to 40 years of age, you can still diagnose keratoconus early, a disease in which the cornea becomes increasingly curved and thinner. So we must focus on this part of the eye, and we must try to do the treatments to stop the evolution of the disease. The cornea that is inexorable becomes more and more curved and increasingly thin. So basically we have two methods that slow the disease. We have cross-linking, a chemical treatment in which the substance riboflavin is absorbed through the eye. Riboflavin, or vitamin B2, is a substance that is found in nature and penetrates through the cornea with the use of transepithelial methods, or removing the corneal epithelium. Our preference is the transepithelial method by iontophoresis, which is a kind of miracle in where riboflavin, vitamin B2, is conveyed by an electric current and absorbed by the corneal layers. This is one of the very few cases in which a drug, a substance, is brought into the tissue without having to inject, take by mouth or suppository. Riboflavin is absorbed by an electric charge, at least in the first 200 to 300 microns of the outermost portion of the cornea. Therefore, the part of the cornea that is filled with riboflavin is exposed to the ultraviolet rays for a period of time ranging from 8 to 30 minutes, depending on the machines. The result is that the riboflavin that is absorbed and activated by the ultraviolet rays creates a cascade of chemical reactions in which the end result is the death of keratocytes, so their population inside the cornea is zeroed in. New keratocytes are then formed that synthesize with the collagen cords that form the cornea and therefore develops a new cornea. This stabilizes the disease and is marked as a very low-risk treatment because of the risk-free iontophoresis. That lasts a quarter of an hour, which can all be done in the clinic. This is, therefore, the therapy of choice for the disease, provided that we have been so good to make an early diagnosis, because, in reality, if we were late to diagnose the disease, when the cornea no longer has a spherical, but a conoid appearance, the only way is to insert plastic rings inside the thickness of the cornea, which are like rods that have the function of reopening the cornea. All this again if our cornea, that should have a spherical appearance, has become conoid, deformed, and thin. We put a rod inside the cornea to try to go back. We basically hit the rewind button and come back for 3, 4, or 5 years. Of course, it would be desirable to always make an early diagnosis and not having to get back to the use of intrastromal ring implantation, nor to corneal transplantation, which is the last phase of keratoconus therapy. However, it is not always possible to make an early diagnosis, to use a topography in all patients, and to be able to diagnose this disease early. The postoperative course of the intervention with intrastromal rings is very light. I would say almost painless. The patient is rehabilitated in 24 to 48 hours maximum, and the ring is not felt and seen. It is a procedure that is 1,000 times less risky than a corneal transplant and can give excellent results in terms of vision. With the intrastromal ring being reaffixed and assuming the most physiological form possible in the cornea, the postoperative course is made very easy to deal with, allowing it to be a treatment that one should not be afraid of. The postoperative course of cross-linking intervention, if performed by iontophoresis with intact epithelium, is devoid of any type of risk, so there are no risks of infections or corneal opacities. Its disadvantage is a more or less intense pain that can vary from 24 to 36 hours, so the patient must take into account an absence from his or her activities for 36 to 48 hours after surgery, after which he or she may resume the same quality of life with no visual impairment. Compared to traditional cross-linking, in which the corneal epithelium is removed, the postoperative course is then much longer, more painful, and above all, the vision after the treatment can be as not good in